meet our goals, get the hospital live up to the things that they said that they were going to live up to. And those are the things that are going to provide us with a way that we can continuously not just monitor but improve the things that we're doing. One of the things that was brought home to me was if we look at the airline industry, they basically pride themselves on their safety records. Their planes take off and they land safely, and they have an excellent safety record. And if we just took that as a measure of their excellence, we'd say that every one of them was excellent. But if you talk to the person that was riding on the plane, they lost their luggage, or they had a delay, or they sat on the tarmac for an hour, well, they didn't have a very good experience. But you have to look at it from a different perspective. So if we're not identifying what our patients' experiences are, we don't know how well they're doing. Functional outcomes can be identified from the post-surgery results, or operational data, the length of stay in the hospital. Clinical indicators will be complications, range of motion, blood transfusion, those kind of things. And the financial data are all the numbers. These are all the numbers that we need to collect. And by collecting these numbers and evaluating these numbers, we can certainly find a more cost-efficient way to deliver the care. These are basically not supposed to leave this room, but these are the numbers if we look at patient satisfaction scores for the major hospitals in the Birmingham area. And we can see that if we look at the composite scores, 74, 71, everybody's about the same. We want our numbers to be in the 90s. And of all the total hip and total knee programs that have incorporated this kind of patient-centered model around the United States, these composite scores have gone into the high 90s, and that's really where we're trying to go. So we want to be significantly better. And I would imagine if you asked all these other people if they thought 75% was a good score, and they would say a pretty good score, and then you ask them what do they think about the other 25% of the people who answered this, well, there's really not too much of a good answer. Questions? I went through it quickly. Sorry. Yes, sir.
I may be at the wrong meeting.
Okay. Well,
40 years ago, I broke my hip, and now I'm in my mid-50s, and I've been putting it off as long as I can. So I got an opinion from a local orthopedic surgeon that based on my activity level, my age, shape, round, that basically I didn't need replacement, I needed resurfacing. Your thoughts?
Well, without having seen your x-rays,
I'm staying. In general,
if we talk about someone who's 50 years old, good bone stock, with degenerative arthritis, and you're having enough pain where it affects your daily life, your quality of life is being affected, certainly hip resurfacing is a very good option. It allows you for further options down the road.
Okay.
But you do risk the problem of having a metal bearing, which is kind of big in the news right now.
That's the business I'm in, metal bearing and engines. I'd rather not have it in me.
Yeah.
I got the answer. I can't hold it.
Were you going to talk about the different procedures for doing the total hip replacement?
I can talk about anything you want to talk about. What I was trying to get across tonight is that we're trying to provide a better way of handling hip and knee replacement surgery. Now, we do every kind of hip and knee replacement here, except for this anterior approach that everybody's so interested in. It's really not a new approach, it's an old approach.
Are you opposed to it?
I'm not opposed to it, but what I'm opposed to is the advertising that it is a better way to do it. When we look at the data for posterior approach, for anterior approach, the long-term data, 15 to 20 years, is exactly the same.
As the posterior.
So it's not really new. That's
No.
what we've been told.
It's not there.
I heard it's better for obese people. Is that true?
The advantage of the anterior approach is that it provides the surgeon a better way to get to the acetabulum or the cuff. But it's much more difficult to get to the femur. The advantage of the posterior approach is it's much easier to get to the femur, but a little more difficult to get to the acetabulum. So really what you want is the procedure that your surgeon is most comfortable with. Now, if you look at the time, the surgical times for people doing posterior approach is about half what it takes for the injury. So you're actually in the operating room significantly less with posterior.
What about the recovery time for both?
Essentially the same.
Is there a lot of danger to the sciatic nerve when you're doing the posterior?
You know, with any surgery, there's things that, as the surgeon, you have to be careful. You have to be aware of where you are and what you're doing. And if you do that, there's not a significant risk. But you know, I think we have to discuss that with our patients when we're having the surgery, because there's certainly a possibility that there could be injury.
Speaking in averages, say a person needed a knee replacement and they went through the conventional replacement, how long would that person figure from the time of surgery to rehab to where they can get back to some kind of normal life?
I'm sorry?
How long would it be for the person to recover from the actual surgery to the rehabilitation and then back to some sort of pain-free or life or whatever?
Again, you know, it's individualized.
Average, just throw an average
Yeah,
out.
when I talk with my patients about the procedure, it's pretty standard. We do the procedures on Wednesdays. The patients are home by Saturdays. We have you up and walking. Sometimes the day of surgery, always the day, the next morning you're up and walking, and you're walking with a walker. We expect that you can walk anywhere from 200 to 500 feet on the first day, and then by the time you're able to leave the hospital, that you're walking independently with a walker for 500 to 1,000 feet. Now, accomplishing those goals is significant because that allows you to get home and start doing things to get into your regular routine of things. And you know, the most important thing is these are wellness operations. You know, you're not going to the hospital because you're sick. You're going to the hospital because you're well and you want to get better. You want to be more active. So we encourage people to move along fairly quickly. But if you say, well, how long is it going to be until I'm pain-free? You know, 3 months is probably a good number. You know, my dad had both of his knees done, and the first one, it took him about 10 or 11 weeks. And the second one took him a little bit longer. He knew what to do, but there's a little more swelling, so overcoming that. So that's kind of my gauge of how Dad did. You know, he was 72, 73 years old when he had it done. Not in the best shape, but not in the worst shape. And you know, you know, the change from a painful gait and pain when you're sleeping, pain that wakes you up at night, to get to where, you know, you have some surgical pain, most people accept that as saying, well, you know, this is going to get better and I can deal with it. So, you know, you're really pretty much better than you were. I would say most people by 6 weeks, you're better than you were when you had the surgery.
Would that be the same for hip replacement?
Usually a little less for hips. These are a little more
Less.
painful. These are bigger joints. There's more pain fibers around the knee than there is the hip. The hip is deeper in the socket. So you tend to get up and go a little bit quicker. Yes, sir.
What's the general service life for a full hip replacement?
Well, if you're talking about a total hip replacement, the data that we have from the 1960s, which were cemented hips using plastic, first generation plastics, is that 90% of them were functioning well at 20 years. Now we have newer data on the newer hips, and really it's pretty close to the same thing. We think the plastics that we're using now are certainly better than the ones we used before. We're not cementing hips in as nearly as much as we used to, so the ingrowth hips are functioning very well. The biggest problem you have is wear, and that wear comes with wear of the plastic. You know, that's where we started to get into the metal bearings. We thought we could reduce the amount of wear, but some of the metal bearings haven't turned out very well. And the ones that are in the news are the PU ASR hips. Those have created some problems, but really the other ones besides the ASR are actually functioning very well. So you know, I think, you know, I tell my patients that 15 to 20 years is what you should expect.
There's no appreciable difference in the metal versus the plastic in terms of the wear and time.
Talking about metal plastic, well, the metals haven't really been in that long to have good data on them. You know, they've been putting in metal bearings for, you know, since the 70s, but really not a significant number of them and a significant number of patients to where you could really see how well they were doing. You know, I think in the early 90s when they really started to kind of explode a little bit. So, you know, we've got 10-year data on them, and they're just as good as
If it were your father's hip, which would you prefer?
At this point right now, I would put a metal and plastic bearing in.
Metal and plastic, did you say?
Yeah, and that's the traditional, the metal-backed acetabulum with the highly cross-linked plastic liner as the bearing surface. And I think,
You make that judgment based on age?
No, I make that judgment based on what the data is for how long these will last. And if we're looking at a traditional total hip replacement, 20 years is really the number everybody talks about, and about 90% of them are functioning well at 20 years. And with the problems that we've seen with the metal bearings, and I think if you went around the country, even the people that were doing metal bearings, my old mentor, John Cuckler, was one of the ones who was instrumental in the design of the metal for the company that whose joints I use, Biomed. And they've never had problems with them, but you know, I think even he's come around since his retirement to say it's probably better to use metal and plastic bearings. Yes, sir.
From a therapy standpoint, outpatient-wise, we're telling our patients about 4 months with total hip precautions. Is that kind of what you're telling them, or what would be your time frame?
Yeah, but you know, with the bigger heads that we're using now, we feel a lot more comfortable in relaxing. You know, when I first came out, it was you couldn't bend past 90 degrees, and you know you couldn't sit with less than 20 degrees of abduction, and those were hard and fast and forever. But now with the bigger heads that we're using, with more stability, certainly I get more relaxed about that. But yeah, total hip precaution for 3 to 4 months. But back to the anterior approach questions that we're having for, you don't have those problems with dislocation with the anterior approach, and that's really what they try and I want to say sell this, because it's the people that are selling the operating room tables to the hospitals that are selling this anterior approach to people. So if you look on the internet and see where all this is coming from, it's a marketing tool by the people that are trying to sell specialized hospital beds for that approach.
But it is true, there's less dislocation.
Absolutely.
But it is.
Absolutely.
I have a question about the recovery time. I had knee replacement back several years ago on my right knee, and I had the surgery in November, and I wasn't able to return back to work until April. And I had problems with blood clots, so I was never able to. You were saying that before you leave the hospital, you'd be able to get up and walk around. I never had that experience in the hospital. When I went home, they sent a nurse. So is that because of the blood clots? Would you do anything? Are you doing anything different?
Well, you know, we use universal precautions on patients for preventing blood clots or DVT. You know, the thing that we worry about is if a blood clot goes from your legs and breaks off and goes into your lungs, it's called pulmonary embolus, which can be fatal. So there's a significant increased risk in patients undergoing total hip replacements for blood clots. So we keep you on something in the hospital. Now, people that are higher risk, we certainly take a different approach than people who are lower risk. But without having any history of having a blood clot, I certainly think that getting up and walking would have been something that we would have done aggressively. Now, if you developed a blood clot while you're in the hospital and you couldn't walk because you needed to be on anticoagulation,